Okay, everyone, it is 4 p.m., so we'll give just a minute or two for people to continue trickling in, and then we'll get started with our meeting for today. So thank you, everyone, for being here. Welcome. Okay, welcome in, everyone. Thank you for being here with us. I am sure people will continue to trickle in the first few minutes. That's totally fine. I appreciate you taking time out of your Thursday afternoon to be here. I'm not sure what the weather is like in some of the other parts of Nevada, but we have had a very strange series of weather events over the past few days that you may or may not have heard about. So we're having some fires up in northern Nevada, also in eastern Nevada. We've seen flood warnings, and then most recently, we around like 2 p.m. today, I think we received a tornado warning in like the Fernley area. So very interesting stuff going on today, and I appreciate you for being here. We're definitely sending our support and healing vibes to anyone in one of these affected areas. So everyone, please stay safe. And thank you for still joining us today. So as we get started, here's our agenda for today. We have a few newsy notes for you, and then we're actually going to introduce a new segment that is our Community Spotlight, where you'll get to hear from one of our awesome working group representatives and the wonderful work that they are doing related to children's behavioral health. We have some updates for you related to our settlement agreement, which includes a reminder of our transformation goals and the role of working group within the project. And then we'll also hear from or about the research on the Center of Excellence, and we'll have some provider-specific questions. So as always, we'll have an opportunity for public comment at the end of this meeting. And if you are not a working group representative, we would love to hear your thoughts during public comment. For those of us who are joining who are working group representatives, we ask that you please add your name and affiliation to the chat so that we can record your attendance for today. And thanks for being here. Moving right along, we have two newsy notes for you today. So starting with the first note, I will actually turn the meeting over to Dr. Christine Pebbles for an update on the clinical assessment tool selection and the overall timeline for screening and selection, or screening and assessment, excuse me.
Perfect. Thank you, Chris. I appreciate it. So I'm Christine Pebbles. I'm a psychiatric and family nurse practitioner, and I serve as the behavioral health clinical advisor on the team. If you've attended some of our meetings in the past, you have met me before, but if you have not, I just want to say thank you for joining us tonight. So just as a quick kind of recap of where we are with the screening and assessment tools, as you can see from this timeline, we've had quite a lot that has been completed, one of which is we've selected the screening tool set, and then we had the clinical assessment tool summit, and that consists of tools like the CASI or the Locust. In July of 2026, we had some discussions, and we've actually selected a clinical assessment tool set. So next slide, please. These are the tools that we have selected. So as you can see from here, there are three of them. The main one that we'll be utilizing throughout the state is the one that we currently utilize. To be completely honest, it's called the CalLocus Cassie. It has been merged. So some of you know it as the Cassie. There's just a little slight change in the name. And this is going to be used for kids from age 6 to 18. The other two tools that you see here on the screen are utilized for kids that fall outside of that age range, whether that be younger than 5 years old. And you can see the ECSII is the one that we use. And then for any children or adolescents that fall outside of that range, 18 and above, that will be the locust. I just want to keep it for you to keep in mind and not panic at that little last bubble there on the bottom that says there has to be training to complete these tools. There does in fact have to be training. However, we just wanted to make everyone aware that we don't necessarily expect you to complete training immediately. I do know that the locust has free training available, which is great. And we'll always give that information out later just so you have a better idea of what that entails. But our goal is for the upcoming specialty delivery system to lead that completion of the assessments. That's in alignment with the settlement requirements. If community providers wish to complete these assessments on your own, that's fantastic. But we don't want you to feel like you have to complete that training right now. So we just want to make you aware of that, that although it does require training, we don't necessarily expect you to complete that training immediately. And so next slide, please. This is the timeline where we are currently. So at the moment, we're concentrating on establishing timeliness standards. So basically what that means is just the guidelines for completion of those tools. So that means when do we expect for them to be completed and how do we expect that to be done? And this varies depending upon the environment. So a child that is seen or an adolescent that's seen in the ER versus a residential hospital versus mobile crisis, it's going to be different. And of course, just as we did before in the past, we're really looking for your input in order to make sure that whatever timelines are developed are feasible and they're actually something that is reasonable for your particular setting. So again, you'll see there in the box to the right, September 2026. This is when we'll have some additional discussions as far as what your expectations are, what your staffing is. And again, just to remind you, the specialty delivery system will share in that responsibility to get these clinical assessment tools completed. So the Cassie, Locust, and all the other tools on the previous slides, just to ensure that if you do have limited staffing, if you have limited time, that you still have access to have these tools completed, and you don't really have to get that training done if that's not something that's feasible right now in your timeline. So please look for information in the near future as far as that feedback is concerned, because like always, we really do value your feedback and we want to make sure that any policies or procedures that are implemented fit with what you're doing currently so we can continue to serve this very, very important population. And again, like always as well, if you have any questions, please feel free to reach out to us at any time. I'm happy to visit with you virtually or in person if that's easier, or you're welcome to shoot me an email if you have any questions. But thank you again for joining us this evening.
Thank you so much, Dr. Pebbles. That was a really helpful overview and appreciate the follow-up on the selection of the clinical assessment tool. I know that has been something that we've been working through as the working group. And so I also just want to take a second to say thank you to everyone in our children's behavioral health community who have been participating in the entire process of our screening and assessment tool selection. So that includes the summits that we hosted, anyone who has had one-on-one or small group conversations with Dr. Pebbles, people who have responded to our surveys asking you directly what you think about each of the tools, and to everyone who shared their perspectives in these meetings. This work was driven by your feedback and will continue to be, as Dr. Pebbles mentioned, as we're drafting the timeliness standards and moving into the implementation of the tools. Our next newsy update is related to an email that you might have received from the Nevada Health Authority Behavioral Health Listserv if you're signed up for it. And if not, we do have a link at the end of this presentation for you to sign up, or you can find the listserv link online. So this update is related to the Department of Human Services, who has issued a request for information to learn more about existing or potential foster home services in Nevada, specifically for youth with intellectual and developmental disabilities. So if you are knowledgeable about residential models, specialized programs, or service approaches for youth in the foster care system who have complex support requirements. This is a really great opportunity to share that information with the Department of Human Services. The information that's gathered through this request might inform a future procurement, and this is an opportunity for you to help shape what would be included. The full request for information can be found on our Children's Behavioral Health website, or it can be found at this link that we will drop in the chat. And then just please note that the responses are due by August 28th, so that we have just over 2 weeks to get some responses in for this. Within that document for the request for information, it includes the target population, examples of the different services or systems that they are interested in learning about, and it does have a lot of information that is really helpful for shaping what this could look like. So with that, I mentioned during our agenda slide that we do have a new segment for our bi-monthly Children's Behavioral Health Transformation meetings, and this is the Community Spotlight. So as you all know, we, meaning Nevada Medicaid, the Nevada Health Authority, share a lot of information during these meetings, and we're diving into some really important discussion topics. But what we don't always get to hear about is the awesome work that our community is doing outside of Medicaid. So moving forward, each meeting, we are going to invite someone to be our community spotlight, starting with our working group representatives. So the format of the community spotlight is fast-paced, fun, and uplifting. It's not meant to be a harsh judgment on anyone's work or on their presentation. So our working group members or whoever is our community spotlight is putting together a presentation for you all to share their work. The style is actually inspired by the Pecha Kucha presentation style, if you're familiar. So what that means is that we are challenging presenters to share about their work in 20 slides that progress every 20 seconds. So that's not a lot of time to share your information, which is what makes it a challenge and also keeps it pretty fun and upbeat and exciting. So with that, I am very excited to invite our first community spotlight, who is Sherilyn Rarwood, who's going to tell us about the Nevada Rural Hospital Partners. And so as Sherilyn presents, please give her support for being our first presenter. We have the really fun meeting reactions, and the whole time that she's presenting, let's keep that rolling. Include some nice comments in the chat. If you have questions, all of that would be so fun. And with that, I'm going to turn it over to Sherilyn.
Thank you. Thank you. Welcome, everyone. Happy afternoon. Hopefully you're not all being drenched with the rain or smoked out by the fires or having to evacuate. Just wanted to make sure that everybody's okay. I'm going to try to stick to this Pikachu, but it was really daunting and hard, and I have to be the guinea pig. So here we go. Nevada Rural Hospital Partners is an alliance of 13 small and rural hospitals founded on the idea that we are stronger standing together than individually. Building on long history of cooperation dating from the mid-1970s, in 1987, with temporary funding from Robert Wood Johnson Foundation hospital-based rural healthcare program, the group established a formal consortium intended to focus on solutions to the issues and challenges facing rural hospitals. Slide. These 13 critical access hospitals serve approximately 228,000 people and are spread over a geographic area about the size of New England. And our NRHP, through grants, donations, programs, and NRHP Foundation, provides those hospitals and rural health clinics financial support, resources, education, quality standards, and initiatives to help our hospitals and their employees. Slide. So just some program highlights. How do we meet all those goals that I just spoke about? Over the years, NRHP has grown into a stable and mature horizontal network with a voice that speaks for rural hospitals. Owned by its member hospitals, NRHP offers a variety of programs, services, and initiatives designed to ensure the viability of the facilities we work with by advocating at the legislative and regulatory levels, reducing costs, generating savings, enhancing quality, sharing resources, and expanding the use of technology. One of our newest since 2020 is our mobile MRI. Currently, the state-of-the-art mobile MRI system serves 4 member hospitals, which will now be increasing these next to 6 hospitals with the RHTP money. We also have our own LICON, which is Liability Cooperative of Nevada, and that is the purpose of that is to self-insure our professionals and related lines of liability for eligible hospitals. So we provide our own insurance for them. Then again, advocacy, and I kind of spoke to that. We are lucky enough to be able to have our NRHP Foundation, and they work with the Nevada State Legislature to really help ensure and support our operating environment for small and rural hospitals. And then, of course, the foundation, which is the nonprofit arm of NRHP, which really is organized exclusively for charitable and educational purposes in order to accomplish specific objectives relating to rural hospitals and medical facilities. Slide. Some other programs, loan pools. So we loan hospitals and other community organizations money, depending on if they qualify or not. Behavioral health is now a new step for NRHP with me in this role, and really working on that hospital care, combining behavioral health with the hospital care and the primary care. We work on performance and quality improvements on a daily basis with Medicare Rural Hospital Flexibility Program funds, as well as SHIP program funds. And then peer work groups. Part of our work here is really to make sure that our hospital employees are supported and feel supported at all times. Okay, slide. Some of the training and education, we work alongside many state agencies as well as community partners, such as the Office of Rural Health, UNR, UNLV, CASAT. There's just a few of the organizations that we collaborate with on training and education. I'd like to point out that one of our hospitals is actually a residency site. We really work on having our own homegrown doctors and nurses. It's really a push for us out in the rural and frontier. Some of the trainings that we offer, we have a wide range from quality risk, infection control, behavioral health, cybersecurity, safe opioid prescribing, and on and on and on I could go. With the RHTP funding, and Nevada Rural Hospital Partners and Nevada are really looking to create more residency and intern programs in our rural and frontier regions, not only in medical, but in dental, vision, behavioral health, and more, developing programs that build our professionals up to be the best clinical professions they can be here for Nevada. Slide. So this is speak a little bit about our NAP program, the Nurses Apprentice program. This has been just a gem of ours, really. One of our workforce goals is to endlessly work to build homegrown healthcare providers. And working closely with universities and small colleges across Nevada, programs such as the Nurse Apprentice program have provided salary and retention bonus to many of the Nurses Apprentice programs. I tried to get the count today, but we really couldn't figure out how many, but I'm talking thousands. And we stretch our reach across of 12 of our critical access hospitals. And I just heard today that Desert View actually hired 3 of their nurse apprentice programs, and for the first time has no openings to hire any nurses. So great program on that. Next slide. So let's talk about me a little bit. This is a new role for NRHP, and I'm blessed to be the builder of this important role. I came to this position having already spent a lot of years working with the cause and the rural health clinics when I was a statewide zero suicide coordinator. And then as one of the 5 regional behavioral health coordinators, I was able to build even more connections and relationships in our rural and frontier counties. And we all know that the juncture between healthcare and behavioral health is so connected that you cannot treat one without assessing and treating the other. My job is to make that juncture a bit more possible for our cause and their communities. Slide. Connector, research, policy, leadership. I get to do it all. I feel so lucky to have this role. There's nothing that I really can't touch as long as it belongs in our rural frontier regions, along with our hospitals and our communities concerning behavioral health. In my role as a policy board coordinator, I got to have a BDR with my board. I don't get to have one of those, but I still get to stay involved with legislation, following all the behavioral health BDRs that we'll be rolling out, and working with Blaine, our president, to talk those through. Grant writing is a big piece of my role as well. We got to keep things funded. We're all looking for money always. Slide. I train a lot throughout the state. Some of the trainings that I provide for the cause and the rural health clinics and the community folks alike. I do a suicide prevention 101, 102, which is really focused on more higher level educated partners, our professionals, clinicians, things of that nature. I'm blessed to work closely with the Office of Suicide Prevention. I partner with them on gatekeepers, assist, safe talk. I myself has developed a few trainings of my own, trauma and effects on health. I do mental health crisis training holds across the state, suicide risk assessment for the CITs in multiple counties. I train on the psychiatric advanced directives, and every now and then I create new ones if they're in my wheelhouse and somebody's looking for a training. Next. This is something I'm really excited about. This is new since I came to this role. I worked very closely with the law enforcement and the counties on CIT, and I saw how well and how productive and the amount of things they learned as a law enforcement when working with our folks in a crisis, whether they had dementia, ID, DD. The training is a full 40 hours, and we really go into a lot. I've been working on creating one for our critical access hospitals. And my goal really is to put together that 40 plus hours in kind of a virtual. And it's going to equip our frontline healthcare workers with practical trauma-informed skills to safely and effectively respond to behavioral health crisis, including incidents involving patients experiencing mental illness, substance use disorder, and emotional distress. This innovative training will also equip hospital staff with the skills and resources to provide that reliable peer support when events such as these happen. Next. Slide, sorry. Signs of suicide. This work allows me to continue to provide signs of suicide training and follow-up debriefing in some of our school districts. This is one of those programs that I get to collaborate closely with the OSP and many of our state partners who do this ever important work. I personally feel this is such a great program for our schools to use to identify if youth is struggling before they even know it. I hope we can bring on more school districts, as this is an excellent program for our school-age folks. Through this program, slide, I was able to develop a curriculum, and it's an 8-week curriculum for groups. I found that when we were debriefing with these kids from that had just attended the Signs of Suicide, a lot of times they weren't at that high risk, needing lots of inpatient or intensive outpatient. They really just needed some therapy with their school social work and maybe a work group. And so I read this book while I was at the Mental Health America, and it's kind of written like Whimper Eve, a Diary Kid. And I was able to create an 8-week curriculum with the groups of these kids. So we're learning how to describe our feelings, our emotions, utilizing words, building their own safe group. So I know who I can talk to when I'm struggling, and then speak up about their feelings. Currently, this curriculum is in Carson City School District, and hopefully it's going to move across the school, across the state as we implement more signs of suicide in more school districts. Next. Burnout and resilience focus. I could go on with this. I know this is something that we probably all struggle and deal with, but within my hospitals and rural health clinics, this is something that I'm really focused on building out, is those peer support teams within each hospital so that they can help and assist other hospitals as well in the rural and frontier region. Next. I still am working on zero suicide in all of my critical access hospitals and rural health clinics, and I'm excited to really push and move this even more forward than I was able to do as the coordinator of zero suicide. So I'll be starting this up at the beginning of the year and really pushing zero suicide out. Changing system-wide suicide prevention in our hospitals for the get-go. Nevada Care Contacts came out of zero suicides, and it's a follow-up program referral. I'd love to share more about that, but I know my time is limited. So next slide. And these are some of the boards and committees that I am privileged to sit on and been invited to join. I'm choosy about what boards I sit on. I really like there to be momentum when I'm sitting on a board, a committee, and so I'm excited about the ones that I get to be part of. Next slide. And for fun, I like to watch any sport as long as it's not boxing or wrestling. I love to paddleboard. That's my getaway space. And then raising my second child with my 23-year-old son is a 160-pound 5-year-old Newfoundland named Gander. Next slide. And that is me in a nutshell.
I was muted.
How many minutes did I do it in?
That was about 11 minutes, but I don't know if I started right on time, but okay. That was amazing. Thank you so much for being our first community spotlight. I think, so I put it here, but if everyone can just do some reactions, give Sherilyn some support. You came in with such positive energy and you were ready to go. That was awesome. And yeah, it's okay. We have wiggle room. We are perfectly on time, so don't worry about that at all. I think that the information that you shared was just so fantastic. We will be posting this on our website, so for anyone who wants to read a little bit more, there will be a description for the slides as well so that you can learn more about those awesome programs. Like I'm so excited about this segment and really appreciative for you to be our first person. So with that in mind, we have just a few minutes where we can answer questions. So if anyone does have a question about something in particular that you heard or wants to come off mute to also share your thoughts on this, please, we'll have just a few minutes for that.
Thank you, Dan, for reminding me to take a breath. I appreciate that. Brittany.
I just have a question. Once you have implemented the Where to Start curriculum and, tried it on, is that going to be available to other providers to facilitate, like
I
through
would
the
love to
coalitions or?
Not to cut you off, but I would love to share it. I created and worked with Christine Sapien, and so we kind of rolled it out last year in her school district because they did signs of suicide. But my information, you have my information. Reach out to me. I'd love to share it with you. I don't bogart anything. I share anything. And we really found that this really was a great way to teach our kids, one, to support each other, and two, how do I describe my feelings? Like we just say, I have anxiety. Okay, tell me what that is.
Yeah.
You need to explain it in words. And we found that kids just struggled with really explaining how they felt. So I'd love to share that with you, Brittany. Absolutely.
I will absolutely reach out to you. Thank you.
And I see that I think Dr. Freeman had mentioned something more. Megan Freeman, are you willing to share? Absolutely. Reach out to me. I will share my curriculum with anybody. It's a T for T. It's written on what do I do, how do I do it, and everything. So I had a couple people help me put it together. So it was really fun to do that. It's really cool to see it being utilized.
Thank you, Sherilyn. I'll reach out.
All right, cool.
Awesome. And just to also know, we got some really cool feedback in the chat. So y'all were a very engaging audience. Thank you for using the React function and thank you for your really sweet notes in the chat. Just to note a few of them, we have some +1 comments like critical access hospitals are so crucial to our rural population. That is so cool. Great job. Well done. Great job. You're doing amazing work. Incredible. I love this one. You are a force and so glad you're leading the way. Agreed. You are amazing. We love Sherilyn. Thank you so much for coming and being our guinea pig, as you said. I hope that that was a fun process for you. And now you can take a breath and just rest for the rest of the meeting. We'll have some opportunity for engagement later on. But yeah, thank you, Sherilyn. Do you have any closing thoughts?
The populations that we touch out in the rural and frontier region.
Yeah.
So thank you for the time.
Absolutely. Absolutely. Okay. Next on our agenda, Administrator Jensen is going to be walking us through a review of 2026 so far. We're already in August, if you can believe it. And then we'll go into some of the settlement updates that we have for you all today. So I will turn it over to you, Anne.
Thank you, Carissa. And wow, Sherilyn, that's a hard act to follow. So really grateful for you sharing and just want to echo my deep appreciation for our rural critical access hospitals. I actually had the chance to visit all 13 of them this spring and summer. I think we drove 2,400 miles over the course of the tour. And I just learned so much, particularly about the way that they're responding to the behavioral health needs of their communities. That's a conversation that came up in nearly each one of the hospitals as they're trying to better respond to what they also view as a growing need, particularly acute for kids in our community. So They are incredibly creative and resilient and doing really innovative work that we can all learn from. So grateful for them and Sherilyn for all you do to support our coalition here in Nevada. So today, I am excited to share a little bit more information about what we've done so far. I know that there's a ton of different kind of pockets of work that we talk about in these meetings, and I always like to take a chance to take a quick step back and think about what's our goal, and then what are the updates particular to each of those goals that we want to share with you, and also preview where we're headed and what things we're going to want your feedback on through the remainder of 2026. So as always, starting with our vision, it's that Nevada children have access to the behavioral health services they need to live and to thrive, most importantly, with their families and in their communities. That's not new, and I know that every single person on this call shares that vision, but I think it's important to start. The whole goal of why we're doing this is to make our system better serve real kids and real families on a daily basis. And we have an incredible opportunity here that if we don't listen and respond to what our families need, we will have wasted. And so we take that really seriously, which is why we have this working group. And so today I'll be talking through 4 main goals that we're focused on to achieve that vision. Those are increase high quality behavioral health services, improve care coordination across all systems, decrease reliance on residential treatment, and through all of that, keep the perspective of youth and families front and center. So we're going to go, I have a slide for each one of these kind of slices of the pie that I'm excited to talk through. What have we done and where are we headed this upcoming year? So if you move to the next slide, Carissa, we'll start with that youth and family voice. And as always, our goal here is to ensure that the perspective of youth and families in Nevada guide every policy and operational decision in the transformation. So every policy change we've made so far has gone through at least one, if not multiple working groups, public workshops, ad hoc deep dive discussions on, for example, those screening and assessment tools that Dr. Pebbles talked about earlier. We take that really seriously, and we are moving both quickly but slow enough that we stop and really take stock of that feedback to reflect it in every step that we've done. So I'll walk through in the next slide exactly what some of those meetings have looked like recently, but I just want to tee up, there's a couple key areas that we're really going to need input on this fall and winter that I'm excited to kind of preview. First is the Center of Excellence that we're building. How do we help providers deliver care based on the most evidence-based practice and do that in a scalable and sustainable way, given everything else on their plates? There's actually an opportunity for input on that today, and that will continue throughout the summer and fall. As you know, we're launching a specialty delivery system, and so a lot more to come on the kind of operations of that as our procurement continues. I'll talk more about that on a future slide. And then we're going to continue to have these deep dive discussions on policy areas of interest with our representatives and really a close hold forum. We know we can't always get to a lot of the details and the really crucial, more kind of deeper topics in this forum, and so that's why we have those ad hoc meetings. So if there's a topic that's really kind of continuing to come up for you, if you're curious how the state's working on it, reach out to us. We'd love to hear and really design those conversations around what our representatives are interested in. So the next slide really shows what those meetings have looked like. Again, we have bi-monthly working groups, so every other month based on feedback from you all. So we have a little bit longer meeting every other month, and then those ad hoc meetings. So we had a May ad hoc meeting on PRTF kind of prevention and diversion and what we're calling speed bumps when entering residential treatment. And then in June, we actually had 2 meetings, one on the Center of Excellence and the other on transition and discharge from PRTFs. So I hope you really see we're trying to find ways to bring all of the updates to this bigger group, deep dives with our policy conversations, and that will continue throughout this year and into the years to come. But we want to make this useful to you all. So if you ever have feedback, we'd love to hear. Next slide here is on the next slice of the pie, which is increasing high quality access and quality of behavioral health care for kids and their families, importantly, that's available at home or in their communities. So a few big wins so far this year. We finally got CMS approval on that rate increase for outpatient therapy services for kids, which includes not only a base level increase for all therapy services, but also putting our money where our needs are, which is to say we're paying more when services are delivered in rural communities and also in home-based settings. That's effective all the way back to January 1st, 2025. We had to wait about 14 months for that approval, which was a big one, but we got it. We're going through that recycle process so everyone's claims are recycled, and we're ensuring that providers are getting that enhanced compensation. We also got CMS approval and are launching the Medicaid coverage of family and youth peer support. This has never been a Medicaid reimbursable service in our state, and we have really excellent providers doing it, but we haven't been able to pay for that from an insurance perspective. And so we've partnered with our colleagues at DPPH and various community organizations. So shout out to Nevada PEP and also to our NAMI colleagues who have been working to support this new certification for these providers. That training is happening right now. We have the first cohorts of folks moving through, and we're really excited to be able to now enroll them as Medicaid providers. The last, most recent CMS approval we got is approval for university training clinics to serve as Medicaid providers of behavioral health services, meaning that master's level trainees and doctoral level trainees are able to enroll and get reimbursed for the care they're providing right now. This is a really crucial aspect of our behavioral health services in Reno through UNR, in Vegas through UNLV, and we're excited for an ability to help pay for that with Medicaid to help that scale and grow. So huge acknowledgements, to Dr. Paul, Dr. Durrett, and Dr. Cooper, who have been supportive of that process through all of the legislative session and all that's to come with CMS. So really excited to see that one come through. Where we're going next, our final benefits that we're seeking approval for are that planned and emergency respite care. This one's a little bit complicated with CMS, and so the reason that it's a January 2028 effective date is that we need to tie it to the specialty delivery system authorities from a regulatory perspective. The good news is we're working on a bridge model, and I'll talk about this in a second, to help continue funding for these services until that system is live, because we know respite is a crucial service and component for our families in the state. We're also seeking CMS approval for first episode psychosis, which is an excellent coordinated care model for young adults with complex needs. Our colleagues at UNR have been doing this model for a long time, and so this Medicaid coverage will be a really crucial step to help support that and scale it over time. And then, of course, we're launching our evidence-based practice training over time through the Center of Excellence. That's earlier in our development stage, and I'm excited for Dr. Woodard to speak about the research on that in a few slides. So that's all the things in behavioral health services world. Our next slide talks about that improved care coordination. Goal here is children and families need support as they navigate a really complex array of systems, state systems, county systems, healthcare systems, school systems. They need an advocate and support to do that. And that's where care coordination comes in. And what I've really heard from you all is it's not just about care coordination. It's about that care coordination unlocking real services and meaningful supports for those kids and families. And so we're tackling this in a couple of different ways. Short term, we added more staff. We got legislative approval to add more staff to our complex care coordination team. Those are nurses and social workers that are working in our Medicaid district offices across the state that are trained specifically in helping kids and families seek complex behavioral health treatment. You can email them today. If you know someone who needs support with Medicaid services, if they're covered by a managed care program, we work very closely with their care coordinators to support that process. So please reach out. It's an excellent team, and I'm really grateful for their work. We also launched 3 care management entities through the Connect Nevada program. I'm grateful for our partners through the Magellan team that invested over $1 million in funding in these 3 care management entities that will be providing care coordination by their staff in Reno and Las Vegas as they train and staff up over time. It's a crucial component of the model that we're building in our specialty delivery system that's really grounded in local providers delivering this specialized care coordination. And I'm grateful that we have that started already. As you know, we launched not 1, but 2 procurements so far in 2026. We learned from both of those, and we're taking that new 3rd approach in late fall of 2026 when we launch our procurement for what this kind of new iteration looks like. As we shared in our last meeting, it's going to look and feel pretty similar to what we put out previously, but it's more focused on the clinical assessment and care coordination piece. And we'll kind of support or layer on top of our existing fee-for-service and managed care delivery systems. As I shared, that procurement will be launched later this year with the goal of an effective date for services in January 2028. But we're going to get them on board in mid-2027 so they can continue to develop that provider network, get ready to go so we have a very smooth launch in 2027 heading into 2028. As I shared, in the meantime, we need to find ways to support our care management entities and services that aren't yet Medicaid reimbursable. So more information to come on that soon, but no, that's a top priority to ensure that continuity. So a lot happening in our care coordination world. Our last piece that I'll touch on here is our decreased reliance on residential treatment. Our goal here is not to eliminate residential treatment. It is crucial, but we need to ensure high quality, short-term residential treatment is available to youth when it's clinically necessary, and that youth can return home successfully as soon as possible. What we've done so far this year in this world is a lot. This has been a big focus for us. First, we secured CMS approval for a new way to pay PRTFs that helps programs that care for youth with more complex needs get additional funding to support the staffing and the further resources that they need. We also contracted with an external entity to do a really comprehensive review of every single aspect of our PRTF regulations and licensure requirements to ensure that we're aligning with national best practices to ensure safe and high quality. Those findings are going to inform some work we're doing on the regulatory and our policy side, which I'll touch on in a second. The very exciting news, and I have one more slide because we got to spend a little time on this, is we got CMS approval for a new type of residential model that is different from what we have for PRTFs right now. And sorry, Carissa, we're going to go back. We'll stay on that side for a second, and then I'll go to that one. So thank you. But the intention is really to support diversion from institutional care when appropriate and help people and kids successfully transition to and from their home-based settings. The last piece we did this year in terms of that residential bucket is actually launched a new quarterly meeting series with every PRTF provider in our state and our out-of-state providers that we work with to review outcomes data, settlement goals, and our policy. We facilitated a peer-to-peer learning discussion and are really trying to ensure that we're working very closely with providers so they understand how their work aligns with our overall goals. Where we're headed, we're taking all of those learnings and that feedback, and we're going to be updating both our regulations and our policy to align with those best practices. As folks know, we have updated our PRTF policy about a year ago. It's iterative. It will continue to update as we learn more, and this is a really key area to focus to make sure that we're supporting youth in the right directions. So now if we move to the next slide, I'll spend a little bit more time talking about what is this new model? What is RRMHC, which is an acronym that I am just now getting right after about 3 months of practice, so no pressure to use the acronym. What it means is rehabilitative residential mental health care. This is different than a really high acuity PRTF, but honestly may sound a little bit familiar. I think what we've called PRTFs in Nevada for a long time, there is a range of types of care in that bucket. What we're trying to do here is say, this is a really crucial model of care that's distinct unto itself, and we need to ensure that we have both our RMHCs, this residential model, as well as our PRTFs to support kids based on their clinical need at that time. So how are these different? They are in home-like settings. So the intention is this looks and feels like living in the community, but you have more intensive therapeutic treatments and supports. So this is at maximum 1 to 3 months of intensive care in a home-based setting with a small group of other youth or adults, because this is also an adult model stemming from a legislation that passed last session. That's intended to be a stepping stone of care, either for a youth that's not successful right now at home and needs another place to be, but doesn't need the clinical acuity to be in a PRTF or a inpatient setting, or someone who's discharging from those settings and needs kind of that in-between step to really gain the skills and tools needed to be successful once they return home. So between that least restrictive and most restrictive kind of continuum, you can see where RRMHCs really stand. And that ties to what the score will, what child's score is on the CASI, right? On their clinical assessment tool, as well as the nuance of that particular child's case that would make them successful in this model. So goal here, decrease reliance on residential care. This is not creating a new model for kids to linger in long-term. This is short-term intended to really support those successful discharges. And the great news, the licensure was approved by the legislature last month. We got CMS approval for coverage in our rates. So right now, providers are able to get licensed and enroll in this model. We know that's a process. So folks have been asking, can my child go to an RMHC today? We don't have them enrolled in Medicaid yet. We're working with providers to do that as quickly as possible. And we recognize there are some models in our community right now that will likely fit with this Medicaid model. And so we're working with them to get them enrolled, but know that this is a top priority for us to really make sure we have a safe and appropriate place for kids that we may not have had historically, which I'm really excited for. So with that, we've completed our 4 kind of circles of the pie. We're going to move into some updates on the settlement agreement, but if you have any questions on any of those things I've shared, feel free to drop those in the chat, and I'm happy to come back to those as we have time or can respond to those in the chat. So thanks, Carissa. So as always, we want to kind of orient you all to where we are in our settlement agreement timeline. This is that really wonky and complicated timeline. Carissa made it beautiful, and I'm grateful for it because I made this first in August 2024 when I first joined the state to start this transformation, and was really trying to lay out what is this going to look like at a high level. So where we are right now is in year 2 of our agreement in 2026. In quarter 3, and there's 3 exciting updates I want to share with this group about things that we're held to do in the settlement that we want folks to be aware. So the next slide is about our first compliance report. So you all have had the opportunity to meet our excellent independent reviewer, Dr. Kelly English, who was charged with really assessing Nevada's compliance with the settlement agreement on a regular basis throughout the 5-year term. You'll see in the blue box all the legal speak in our settlement of what is kind of what she's held to do. But bottom line is the first compliance report was finalized this summer and is available on our website right now. So you should be able to check out our website or even click this slide because Teams is getting extra fancy, and you can see what her compliance report looks like. You'll see in there are some things that Nevada's compliant on. Most we're in process or moving towards compliance, and others we're not yet compliant because we haven't been able to start them yet, given the sequencing of some of these items. I'm really grateful for her very thoughtful approach to this and hope you all will enjoy getting to see a little bit more of how her view is of our state's compliance. Next update is on the kind of companion to that compliance report, which is the state's implementation plan. So independent reviewer is charged with assessing compliance. Implementation plan is our kind of update on this is what we're doing and how we're planning to become compliant with each item in that settlement. So we first published our implementation plan earlier this year. That's available on our website right now. But as you can appreciate from those last slides, it's been very busy since February of this year. And so we are going to be adding a supplemental update, with a kind of narrative summary of here's what we've done since the last implementation plan, and here's where we're headed, to ensure that the Department of Justice and our independent reviewer, and of course our community, is prepared to or has fully aware of where we're at in this process. We are finalizing that memo now. Once it's shared with the Department of Justice and Kelly, our independent reviewer, we'll post that to our website. So just want to call out, it's not available on there yet, but it will be likely very soon within the next 1 to 2 weeks, and look forward to any feedback that you have on that important kind of update to our work here. Third update here is on our data reporting dashboard. I'm really grateful for our excellent Office of Analytics and our team that's been working to really translate how do we communicate all of the data about our focus population, both to the Department of Justice and also publicly in a really accessible dashboard. If you click that link, you'll see the dashboard available now. The one data point I want to call out that I'm really proud of, you'll see in our latest quarterly report that for youth in the focus population in the settlement agreement in 2025, our placements in PRTS dropped from 32% to 15%, which is huge. We recognize that in itself, we can't rest on our laurels. There's a lot of work to do, and those numbers will continue to fluctuate over time. But I think it's an important win that we don't always do well at celebrating the wins, and I'm really proud of that and want to acknowledge the hard work of this group that's informed the policy and operations items that we've taken to help improve access and support for kids beyond just residential treatment. So those are our 3 exciting updates. I'll leave you here with just a quick update on the on our website. This stuff I know is so crucial, and it's sometimes hard to find things. And so I'm very grateful to Carissa and our team and our and Kai Plaskin, who's working to update our children's behavioral health webpage to make it more easier to navigate, more organized, and more functional. But we have added a lot of things on the report right now on the website. So if you're interested in finding things, take a look. We're going to continue to refine this in the coming months. But if you're ever looking for something that you need, reach out to Children's Behavioral Health and we'd be happy to support. So with that, I will close my update. Sherilyn, I definitely was longer than 11 minutes on my end, but I hope it's helpful to kind of orient folks to all the things that we're doing in this world, and happy to take any questions. So Chris, I'm seeing that many of these questions are being answered already, which I'm so grateful for the team. I'm seeing Carly's question here. So for situations where a youth is being discharged from a PRTF and the family does not feel safe bringing them home, will RRMHCs be able to facilitate that transition without child welfare involvement? Carly, I really appreciate the question. I definitely recognize this is a situation that many families are in where it's really, how do you find a safe and appropriate place? So discharge and placement in either a PRTF or an RRMHC is always going to come down to clinical need and medical necessity. What is that child's clinical need and what does their treating clinician believe is an appropriate place for them to be? Our intention is for RMHCs to allow for a clinical opportunity for folks that are not at that high acuity level of need, but below that, that would benefit from additional support before they return home. So I do hope that that will help. But that discharge and placement in either setting is really going to come down to that medical necessity. And that's where the care coordination and the family peer support that I know your organization is leading the charge on will be really crucial to also kind of wrap around that family during a really crucial time. Is that helpful to answer your question?
That is helpful. Thank you.
Yeah, absolutely. Thank you. Right. I think the remaining questions in the chat have already been answered. So thank you, Sarah and Dr. Pebbles. Any other questions that folks may have before we move forward?
Hi, Anne, this is Karen.
Yeah.
I'm just wondering on the consultation or the care coordination email that you have here,
Yeah.
is there a timeline for response on that?
Yeah, I appreciate it. So our team is monitoring that, during all open business hours. And so our intention is to respond within 3 business days at most for any non-urgent items, but as quickly as possible for urgent ones. So if you're having trouble getting a response, don't hesitate to copy myself or our Children's Behavioral Health inbox, but I'm confident that our team should be able to reach out to you pretty quickly on that piece. It's really, we recognize a lot of that outreach is critically urgent and our team is great at responding.
Thank you.
Yeah, absolutely. And Sherilyn, seeing your hand up.
Yeah, I was wondering if the state was going to provide the CASI training. I know Locus is free. CASI comes sometimes with a cost to it. So I was wondering if CASAT or somebody was going to pick that up to help us train our clinicians in CASI.
Question, Sherilyn, and it's an excellent segue into our next section of our presentation. So the real goal of a Center of Excellence in our state is to provide evidence-based training and support for high quality care delivery, and training on tools like CASI would absolutely fall within that realm. So we can actually just make this transition right now. We team me up perfectly to Dr. Woodard and Rachel. Carissa, I'll let you kind of introduce them, but the intention is for us to utilize this model to support providers. And so I don't have details for you today on exactly what that looks like for CASI specifically, but know that that is absolutely within scope and things that we're working through right now.
Perfect. Thank you.
Yeah.
Thank you so much, Anne. That was really just a great overview. I said it right before you came on, but I can't believe it's already August. So thank you for walking us through what we've done in 2026 so far. It's been a very engaging year for the transformation, and this is just year 2. So it's exciting to think about where we're going to go from here, seeing what we've done so far. Moving into our next agenda item, as you all may recall, back in June, we learned about the research project that Bowling Business Strategies has been working on for the development of a center of excellence focused on children's behavioral health. We met with them again in our July ad hoc meeting, where we asked you all more nuanced questions about engaging with the Center of Excellence. And today we once again have the pleasure of being joined by Dr. Stephanie Woodard and Rachel Faulkner, who are going to share their progress as we're nearing the end of that research project. And we have some additional research questions, discussion questions. So stay tuned. We would love to hear your responses to those. And with that, Dr. Woodard and Rachel, I am turning it over to you.
Thank you, Carissa, and thank you, Anne, also for the lead into the presentation. I would say this is a collective effort, and there have been a lot of strides forward since the last time we met with you, and some key decisions that Nevada Medicaid has made that are really informing the design and initial plan for implementation of the Children's Center of Excellence. Next slide. So our brief agenda today, we will talk a little bit about what it means for a Center of Excellence moving policy into practice, the follow-up for stakeholder engagement, as well as some of the lessons learned from the Centers of Excellence that we have spoken to across the U.S. review those Center of Excellence decisions that Nevada Medicaid has made, and offer an opportunity for this committee's engagement. And then we'll move on to wrap up and next steps. Next slide. So just as a reminder, the requirement does not exist for a Center of Excellence in the settlement agreement. However, there are several requirements in the settlement agreement that can be directly tied to a Children's Center of Excellence. And what we have learned over our exploration with other COEs across the US is that they really have been pivotal in helping to support implementation and drive transformation in states that have also had similar settlement agreements. So really helping to review and identify evidence-based practice or models. And so you're going to hear me talk today a bit about evidence-based practice as well as best practices. We recognize that EBPs are really, they're very coherent and cohesive packages that sometimes need a bit of translation to really be able to be applied and scalable within large behavioral health systems, including states. The settlement agreement also requires the state to establish a team of individuals with knowledge about the agreement and how they are able to really provide technical assistance to child and family teams for the focus population. Also, that the state will develop provider capacity to address particularly behavioral health needs, largely driven by EBPs and best practices, and then also making trainings available for community and home-based providers so that we can ensure that there is competency in the provision of services that are being provided. Next slide. So we have had an opportunity to meet with a handful of centers of excellence across the US. So we have spoken to the University of Connecticut Innovations Institute. We actually spoke with Medicaid in California, who has launched a Children's Behavioral Health Center of Excellence through UC Davis. Spoken to Case Western University in Ohio for innovative practices, and then Illinois' Provider Assistance Training Hub, which is also known as PATH. Next slide. So as we have been engaging the COEs, we've used a relatively semi-structured approach. So we developed an information gathering tool to gather some basic information from them, including detailed information related to what was the impetus for their creation. And I will say that the way that these COEs came to be is very different across each of the 4 states that they are in. We also talked to them about what were those first few years like when they had started, and then where are they now, and what were their developmental milestones, what were their pain points, what are some of the lessons learned. If they could go back and do it all over again, what would they have done differently? One of the things that we have realized is that there's actually this interconnected web of national COEs that work and to support state centers of excellence. This is often because states are selecting evidence-based practices that tend to be relatively proprietary. And in order for that state to be able to implement on the ground, there is a fair amount of translation of that evidence-based practice to practice standards, so that so providers understand what the standards are in order to be able to implement the services. And then oftentimes there are components related to fidelity and quality reviews, data collection and reporting, and a number of other functions that COEs provide. So we're talking to them and gathering a ton of information. The conversations are ongoing, but the preliminary conversations have really been, I think, very illuminating for all of us to better understand what it actually means for a Children's Center of Excellence. And I'm going to share some of those takeaways in just a second. Next slide. So COEs really occupy this space between policy and implementation into practice. So we all know that we can have policy and the policy can be very clear and well written, but when it comes to actually understanding what does this mean on the ground level for delivery of services, how can we make sure that everyone who's delivering the service is doing it in a way that is consistent with specific standards, oftentimes that are pre-prescribed through an evidence-based practice or delineated through best practices. So the role of the COE really has been instrumental in the states that they are in to do things like help the states select evidence-based practices and to tailor service delivery design to the states themselves. You can imagine every state has a slightly different service delivery system. And so making sure that there is continuity across those practices. They often provide policy and financing consultation, establish provider standards, help to support the development and measurement of quality benchmarks, ensure that there is regulatory alignment, and also support provider readiness and recruitment. Oftentimes when we have services that are new services to a state, what COEs have found is that it's necessary, but it's not sufficient to really help providers onboard those services. And so the COE really does act as a bridge between the policy and into practice. They often help to assess provider readiness to be able to provide a service and then provide tailored training, technical assistance, and coaching to support them as they begin to move these practices into their day-to-day operations. They also support implementation, so fidelity and quality reviews, continuous quality improvement at both the state level and also the provider levels. So it's one thing to install a best practice or an evidence-based practice into your clinic. It's another thing to engage in continuous quality improvement so that you know and understand your own data, and to have someone coach you along the way can certainly help you to refine some of those practices. They also can provide community education and engagement. So not everyone will know what an evidence-based practice is, how it works, or the specificity of it. And so often they're providing community education and engagement around these, really helping to support schools, parents and caregivers, and youth know and understand what this array of services actually look like. And then ultimately leading to practice transformation. So not only achieving quality and fidelity, but maintaining that quality and fidelity over time. And this really is an iterative process. So while it seems like this may be linear, there really is no end to it, because as the state continues through the transformation, they will continue to be selecting evidence-based practices and identifying best practices that they really want to see effectuated within the children's behavioral health system. And the COE is really pivotal in being able to help to drive some of that into the community. Next slide. So the COE in the states that have installed them really see the children's behavioral health ecosystem as made up of many different parts, where the Center of Excellence is only one piece of that. And so when we've talked to people about what do you think a COE is, there is a lot of different ideas around what a COE is, what it's going to be able to do. And it is part of, but it is not the entire system to be able to drive some of this transformation. And so states who have done this before have really seen that being selective about the evidence-based practices on the front end, recognizing that you're oftentimes building an entire system, that it can't all happen as simultaneously as we would like. And so to prioritize those evidence-based practices that we know are absolutely essential and pivotal, while looking ahead to be able to identify other ways that we can help to support the integration of new or scalable practices within the community. Next slide. So we've also done stakeholder engagement. We have spoken to members of both UNLV and UNR, primarily to better understand what are their current capabilities and capacities when it comes to a center of excellence. We certainly do not want a design to duplicate what people are already doing, if anything, to enhance and augment what is already being done. So these conversations have been really critical to understand where our universities are in being able to support providers in the community in onboarding evidence-based practices and best practices, but also to be able to provide all of the other ancillary, but core services of a COE, which include research and evaluation, policy and financing development, and ongoing community engagement. And so certainly we want to make sure that we are optimizing our universities to the best degree possible, knowing that in other states, it really is the university system that is typically housing centers of excellence because they have so much reach into a number of different kinds of expertise. We've also spoken to Kelly English, our settlement agreement independent reviewer, and Deborah Harberger from Innovations Institute. They are also associated with UConn, and so better understanding sort of the origin story and development of the Innovations Institute has been key to this, but also really knowing and understanding how there is alignment between what a Center of Excellence in Nevada could provide and how that can help to support moving towards compliance with the settlement agreement. And then, of course, we've had an opportunity to meet with all of you once, and then we did have an ad hoc meeting, and we're going to talk a little bit about the information that you all shared with us. Next slide. So we had an ad hoc meeting with this group. It was a small but mighty group, and there was a lot of wonderful dialogue in that meeting. We wanted to ask you all some pivotal questions. And so we asked things like, what was the most important need or challenge that you think the COE should keep in mind as it begins developing its foundation? What partnerships or collaborations should the COE prepare to strengthen as it grows? During the early years of training and workforce development, what types of skills or supports do you think would make the biggest difference for youth and families? And then as we begin to build toward a fully functioning center of excellence, what would you hope the long-term impact might be? And you all shared very generously from your hearts and minds. And so we're going to talk a little bit about what those findings were. Next slide. So they centered around some primary themes, themes like being family and youth centered, ensuring that there's support for families and helping children at home, increasing youth and family engagement, and person-centered, strengths-based, culturally responsive care. We also heard quite a bit around the need for workforce training and ongoing support. So finding ways that the COE can align with existing training efforts, again, not to duplicate, and also to try to address any gaps, expanding training opportunities, and the real need to provide coaching, consultation, and implementation support to sustain long-term adoption of evidence-based practices. Breaking down silos across schools, providers, insurers, and community organizations really was an indication of better coordination across systems that you were seeking, as well as to ensure that there is a clarity of roles between the Center of Excellence and formal and informal partners within Nevada's behavioral health ecosystem. I'll pause here so you can take in the rest without me reading them all to you. But again, a lot of really great information that you all shared with us. And we actually have some additional questions for the advisory committee today to be able to continue to provide us input and feedback as the state is considering the Center of Excellence design. Next slide. So supporting implementation of evidence-based practices, I've already touched on this before, but COEs typically are charged with workforce development, both in the university pipeline as well as in the community, supporting training, technical assistance, coaching, and ongoing practice improvement. Next slide. So the state has done some work since the last time we met and has delineated the initial evidence-based practices that they would like to see Nevada's Children's Behavioral Health Center of Excellence be able to support moving into implementation into our communities. High fidelity wraparound, intensive home-based treatment, and under that umbrella of intensive home-based treatment are a number of other evidence-based practices, including multisystemic therapy, integrated co-occurring treatment, intensive home-based treatment with high fidelity, and trauma-informed care. And then to continue to work towards ensuring that we have access in all of our communities for mobile response and stabilization services. So those children's behavioral health targeted mobile crisis services. Next slide. So what we would like to know from all of you, because provider readiness is very important as we think about where the COE begins its work, To better understand how knowledgeable your organization is with implementing the selected evidence-based practices. So I think, Carissa, we can probably just put it in the chat if that's okay with you. Oh, we've got a
Did
poll.
create, yes. So just don't go to so it's just one poll. We have 5 questions total. So we're just on the first one now, and then we'll transition to the next ones. So it might make you do all of them. It's my first time doing a poll, so bear with us, but you can choose multiple options.
So what we're looking for is how knowledgeable your organization is with implementing the selected evidence-based practices. Not awareness, but if you're actually thinking or contemplating or trained, or if you feel relatively knowledgeable and or competent in the implementation of these practices. So your options are not at all. All of these would be completely new to our organization, which is completely fine because we haven't really had a full court press to really bring these services to community providers before. If you are somewhat familiar with what they require, but not currently trained or implementing any on the list, maybe you've started learning or training on one or more of them, but you're not quite implementing yet. If you are implementing one or more and feel relatively knowledgeable, or if you are just expert and you are implementing one or more to fidelity and you could teach others. Carissa, I can't see the back end of the poll, so I'll let you cue me when you feel like we've got some responses.
Okay. Yeah. So as I'm looking at it, there are multiple questions in it. So we might just have to launch the same poll, or
Okay.
I'm going to work on creating a new poll for the next questions. Yeah, and then we can see what these results are.
Perfect. Okay. So we can probably move on then to the next slide because I think there are more questions there for this group. Great. And would you mind pulling down the poll just because I can't see
of
the slide?
course. Sorry about that.
Thank you. Okay, so some additional questions for all of you. In your experience, and so we're really just looking for your experience, in your experience, what do provider organizations need in order to evaluate if they will adopt an evidence-based practice or best practice? So what would you need in order to even make the determination if you want to move forward with adopting an EVP or a best practice? Then in your experience, what do provider organizations need to fully implement evidence-based practices and best practices? Also, in your experience, what are some common challenges providers face when onboarding evidence-based practices and best practices into their practice or their organization? And then finally, what are important factors you recommend the state and Center of Excellence consider when selecting and working with providers to implement evidence-based practices and best practices?
Okay, so I'm reopening our poll. Because it has all of the questions included, I actually think that's a great way that we can collect it all. So you can start with the first one that has multiple choices. So maybe you do fit in between two of the options where you're somewhat familiar and maybe you have tried one or more and it just feels better to choose more than one. You can absolutely do that. And then if you click the little next arrow, it'll bring up, it's coming up as a word cloud, but I will just say I practiced how many words you can put into it, and I did not find a limit. So please feel free to have a lengthy response if that's what feels best. And then also, if you're struggling with using the poll function, you can absolutely come off of mute and we can chat about it for a second. Or you can also use the chat, and we'll make sure that all of the feedback is collected and reflected in anything that we do moving forward with this feedback.
So Carissa, I'm mindful of the time. I want to give everybody some opportunity. So can we keep the poll open perhaps while we finish up the presentation?
Yeah, we absolutely can. And I mean, you can definitely practice and see if you hit the X arrow, then maybe it brings up the slides again for you, and then I can keep advancing slides.
Great. Okay.
Okay.
We're ready then. Next slide, please. So as I mentioned before, Nevada Medicaid has made some other really key decisions around the other core essential functions of a center of excellence in the design for Nevada. And they include ensuring that the Center of Excellence will be available to provide policy and financing expertise. Oftentimes, this comes to support policy and best practice refinement. As I mentioned, oftentimes states are translating and augmenting best practices to really meet the needs within their children's behavioral health system. And so we recognize that those nuances are actually very important and vary state to state. So to be able to support the state and Nevada Medicaid in doing things like establishing practice standards. Also, their support with research evaluation and potentially data linking capabilities. We know that having some data to really drive decisions is very important. And then to be able to support quality assurance, fidelity reviews, and evaluating outcomes. They also would really like the partnership, engagement, and collaboration from a center of excellence, recognizing that outreach and engagement is a core offering of a COE, and to ensure that they're available for public education on the models of care. And then I know there was a mention earlier about CASI and CalLocus. Nevada Medicaid has also decided to move forward with implementation support for service delivery models and standards of care. In this case, to launch initially with CASI CalLocus training, as well as to support the uplift of respite providers. So if you are out in the community and you know that you or your staff really could benefit from CASI CalLocus training, please know that Nevada Medicaid has recognized that this is really a cornerstone to a fully functioning children's behavioral health system and has prioritized this as a practice to be able to promote. And then if you are a provider in the community that is contemplating lifting for your organization planned or emergency respite, that you will not be alone in this endeavor, and that the COE would be walking beside you to support you as you develop that level of care. Next slide. And then there are some considerations. So there has been no decision yet, but what we have looked at is, again, those 4 states and the different models that those states are using. And so California's model is that they actually procured and contracted with a third-party payer third-party administrator that contracts with and coordinates national and state COEs. And then there are other models, including the Illinois model, that works directly with a higher education institution that contracts with universities. The way that both of these work, it's relatively nuanced, but essentially what Nevada Medicaid has decided is that they're going to move forward with designing a procurement strategy for really a hub and spoke model, recognizing that there will be a coordinating entity or organization that will then work with national and state centers of excellence to ensure that there is a comprehensive and cohesive Children's Behavioral Health Center of Excellence for Nevada. So no major decisions here yet, but they have moved forward with at least demonstrating that they're wanting to investigate the potential for either of these 2 possible structures, which will then lead to the design of the procurement strategy. Next slide. So some next steps, we're going to continue to learn from those existing COEs. We are going to continue to have those conversations. Every time we talk to them, we get deeper and deeper into really knowing and understanding what it is that they do and how they do what they do. And then we will explore that COE structure and continue to design procurement strategies, and then refine the scope of work for the Center of Excellence for years 1 through 3, recognizing that just like providers, the COE is going to need some time to really ramp up and to be able to meet providers where they are at. So looking at feasibility, readiness, and scalability are really critical when thinking about how to import the evidence-based practices and best practices into our state. And I think that's it, Carissa.
Thank you so much. So if anyone does have questions, please add them to the chat and we can spend a few minutes answering them in the rest of our time in this meeting. I'm just going to leave the poll open until we close out our meeting so that people can continue responding since they are grouped. I don't want to accidentally close it and someone's responses aren't able to be submitted. So definitely submit as soon as you're able to, just so that we can see what that's looking like. I'm not sure if you're able to see the results of the poll, but I can say at this point right now for our the question on the different levels of readiness or how you feel about the evidence-based practices. We have 0%. No one has responded for not at all, that they all of the evidence-based practices would be completely new to their organization. 14% of responses for the somewhat familiar, but they require with what they require, but not currently training or implementing. 14% for the level of we've started learning and training about one or more of them, but not implementing yet. 50% of responses are at the we're implementing one or more and are knowledgeable, and 21% have said implementing one or more to fidelity and could coach others. So thank you so much to everyone who is responding to the poll. In alignment or in addition to the feedback that we received during our ad hoc meeting, we'll definitely put together your responses to those remaining 4 questions and get that out to you all in a feedback summary of sorts. So thank you so much to Dr. Stephanie Woodard and to Rachel for all of the amazing work that you have done since starting this research project and really going into so many details that I was lucky enough to be a part of that team to see some of the details that went on, and so many really amazing questions were asked that really have helped direct where we're potentially going with that Center of Excellence. And it's been really cool to be a part of that. So with that, we are nearing the end of our August working group meeting. So I want to say thank you to everyone for making it to the end with us. We really appreciate your engagement during these meetings. And I know it's a lot of information, and hopefully we're keeping it lively, keeping it fun for you all, and that this feels like a meaningful use of your time. I have just a few wrap-up items for you all. So we'll go to our wrap-up. And really my main focus is just to say thank you. We did have our new community spotlight segment. So again, thank you to Sherilyn for sharing about the Nevada Rural Hospital Partners. That was such an awesome piece of this presentation and of this meeting today. So thank you again. Our next Children's Behavioral Health Transformation meeting is scheduled for Thursday, October 8th from 4 to 5:30 p.m. And it's so surprising to me that the next time that we are going to meet is going to be in the fall season. So hopefully everyone will be feeling really cozy. Maybe we can share a poll of what Bev you're bringing to that meeting for fall. And so thank you so much, everybody, just for being here today. And at this point, we haven't picked out an ad hoc meeting for September but we're going to start talking about that, and we'll send out a message to our working group representatives about what that might be. So I'm going to move us into our public comment period. So if we have anyone who would like to provide public comment, we would kindly remind you that you will have 3 minutes to speak. And you can raise your hand to indicate that you would like to give public comment, and we will call on you. Okay, we might not have any public comment today. It's crazy. I mean, we can stay on the call just in case anyone has something pop up that you would like to share. I'll stay on until 5:30, and then if not, y'all can start heading out for your evening, and I hope that you stay safe in whatever the next few days have in store for you. Have a nice weekend. Have a nice few months until we're all together again. And just thank you, everyone. You're working hard every day, and we know it, and we appreciate the hard work that you're doing. So thank you for taking time to be here with us and hearing about what we're doing. And I'm going to close the poll. So if you haven't submitted your responses yet, now's the time. Thank you.